Professor Rowinski. Professor Rowinski is a professor of surgery in Warsaw University. He's a national figure in Poland in kidney transplantation, involved in its development since 1966. He has visited Saudi Arabia on multiple occasions, and we enjoyed his company in King Fahd Kidney Center. And he would like to speak to us about expanding organ donors' criteria and outcome in transplantations.
Dr. Abdullah, Dr. Turki, Dr. Abdul Majid, Assalamu alaikum, welcome, and it's a great privilege to be here. I'd like to extend my thanks to Dr. Abdullah and Dr. Faisal for invitation. I am in a very difficult position because to talk after two such elegant presentations, it's a difficult task. As all we know, the transplantation numbers are growing, and the survival, it's very good, but it differs depending on the type of the donor and depending on the organ. The liver transplantation, for instance, from the diseased DCD donors, it is worse than from the others. In European Union, approximately, also it's growing, but approximately we have 37 transplants per million of population in comparison to other countries. And the needs are enormous, as everyone knows. The gap is still extreme, despite our efforts to increase the number of organs available for the recipients. This is from the last SRTR data, the wait list in comparison to the number of transplants for kidneys, for livers, for heart, and for the lung. So we can imagine what sort of a problem we have. The same in Eurotransplant. The gap between the number of organs which are available and the number of transplants is enormous. This shows the gap for the heart recipients waiting for the transplant. This is the graph showing the gap for the liver transplant recipients in the Eurotransplant area. We all know that the mortality rate on a wait list is high, and it depends on the age of the recipient. The highest for people who are over 70. This is for the kidney. The 1 year graft survival for kidney, liver, heart, and lung. This is from the last SRTR data article. Graft survival is quite good, but it differs when we compare the living donors for the kidney and diseased donor, and this applies also to the liver. As we know, we can have a number of different types of donors, and I am not going to talk about the living donors because this is not the task of my presentation. And then we have sort of a mixture of abbreviations. Standard criteria, DCD, extended standard, extended DCD, extended brain death, or whatever. Just one slide showing that searching for the greater number of organs for waiting recipients, as Artur Matus is saying, dying on the wait list, some centers are using extended criteria living donors. I will not discuss that point. I am very much against, because there are no data, no long-term follow-up data on the donor's health in such a population. What is the difference in between the ideal and marginal or extended criteria? In a daily life, it's easy. because it's easy to recognize that this lady differs from the other. The definitions are obvious and everyone knows: brain death and donation after cardiac arrest. The third category of Maastricht, which is a planned withdrawal of the life support. We will have a lecture on ethics of that particular type of donors. The standard ideal donor everyone knows, and if not, we call him an expanded criteria donor. There are so many ECD definitions, and I've learned the new one from the lecture of Dr. Monaco today, that it started with the donor age, then UNOS classification from 8 or 10 years ago, disease donor score of Nyberg, donor histology Remuzzi, DOPKI, which was the effect of European Commission project 2 years ago, and there are definitely definitions organ-specific for liver, lung, and heart. This is from the SRTR article, and we can see that there is a mixture of extended categories among disease donors, and I will not discuss that anymore. The UNOS criteria, which Dr. Delmonico was one of the key leaders in developing them, it's more than 6 years of age or lower age, and one of the, at least two of the following aspects: hypertension, creatinine, or now the current discard rate, as we learned, is approximately 20% in total, but I would join Dr. Professor Rowinski saying that if you have to discard them, send them to Poland, and we will transplant such kidneys. The disease donor criteria of Nyberg, he has developed special score taking into consideration age, hypertension, creatinine, cause of death, and he showed that the number of scores relates to the time of graft survival of kidney transplanted. Histologic criteria of Remuzzi, again, age and number of glomeruli which are sclerosed, special type of scoring, and in Italy, for instance, they are still using this to discard or to use the kidney. Now, the DOPKI, which was developed 2 years ago in European Union, combined ECD criteria, age, and DOPKI criteria, which are marked here, because extended category donor is also the donor which Dr. Pruitt was talking about, the person who had been infected and we may transmit the disease. I will not show the exact results of DOPKI criteria and survival. Now, the number of ECD, by whatever criteria, and DCD kidney donors is growing because of the shortage. For the other organs, we have some recommendations. This is from Brazil. They prepared the recommendations, the risk factor which do matter, and they do use some of such hearts with a longer ischemia, with a trying not to use the female donor either for the male or for the female, but these are the risk factors for the heart. A similar categorization of the risk factor was presented in Brazil for the lung donation. Age, chest radiogram showing some abnormalities, some secretion, and eventual prior cardiopulmonary bypass. Now, what are the problems associated with the extended category donors? First is allocation. We've heard a very elegant lecture, and I will not mention this anymore, but the recipient should know. And so the consent of the recipient is extremely important. We have to remember that the results are inferior in regard to the, for the kidney, in regard to the delayed graft function and rejection. But on the other hand, we have to also remember, take into consideration the cost. But the survival, even lower than for the kidney than from the standard criteria donor, is superior in comparison to the life on the waiting list. This is from one of the articles taken a calculation of the costs associated with the transplantation of standard criteria versus ECD and DCD kidneys in comparison to dialysis. The difference is obvious. The outcome of transplantation depends on a number of factors related to the donor, to the recipient, and to the time in between, which is the ischemia, which is a very deleterious factor, the type and of preservation, and the reperfusion injury. The overall survival, as I mentioned, is lower in patients with a cerebrovascular death and higher serum creatinine. Now, I'm talking about the results now. The living donor, 1, 3, and 5 years, non-ECD and ECD donor. The difference is obvious. Poorer outcomes relative to non-ECD organ transplants are evident from after 1 year from transplantation. And you can see in dark blue, navy blue, patient survival, and lighter color, graft survival. And this is from ECD donor, 1, 3, 5, 10 years, from non-ECD donors, and from living donors. The living donors giving the best results, which is known. This is Ojo, very old paper from 2001 showing that the ECD versus standard criteria donor, the graft survival is much different, statistically significant. But this has improved. Results of transplantation showed by Tector for liver, for kidney, for this is patients, this is graft, and this shows some improvement. Now, clinical outcome, if we compare rejection, delayed graft function, 1, 2, 3, 5 years, survival, again, it differs. If, when we have the extended criteria donor, the 5-year survival is 70 in comparison to 82 in standard criteria donor, and with DCD kidneys, 81. How can we improve the results? This is very important factor, improve the donor management, and this is up to our colleague anesthetists. Take into consideration the preservation techniques. Rutger Pluk for Eurotransplant performed the prospective study 2 years ago showing the superiority of machine perfusion of all kidneys, which they did during that year. For the liver, we did the similar study some few years before. I will show you in a minute. For the liver, normothermic reconditioning, Dr. Clavien showed this in last ATC Congress, and organ allocation, which Dr. Delmonico said, and possibly adapting immunosuppressive protocol. These two kidneys are in a water perfusion machine. This is from our own center. And there are some indicators of viability. The most important probably is the high resistance index, which is much higher, but still, and the flow, but still it's not enough specific and sensitive. But when we did the prospective study, after 10 years, there was a difference in between recipients, graft survival, between recipients who received kidney which had been cold stored in comparison to this which was perfused with a machine. The same returned to dialysis kidneys, which had been cold stored, and I'm ending in a few minutes, and machine perfusion cold storage. Allocation I will skip, and then I would like to show a few data on liver. This is from the paper of Cascales from this year, the control group and study group of donors, DCD donors and the liver transplantation. The difference is seen. Extended criteria, not DCD liver organs. The risk factors are as follows: longer ischemia, higher AST, higher sodium, macrosteatosis, and two other factors which are mentioned here. And if we combine these criteria, the cumulative effect of these extended donor criteria is very nicely seen. When we have three factors, risky factors, the survival for the liver is lower. This comes from the liver transplantation paper 2 years ago, the patient survival and the graft survival in patients who received DCD liver grafts. Now the last part is NHB, which means non-heart beating donors, and I will skip the 1 and 2. I will just want to mention that Spain has made a real progress, because in Madrid they are using a number of organs from DCD donors using special protocol which requires legal regulations and some very specific logistics. The results of kidneys from such donors are primary non-function 16 in comparison to 5, and DGF up to 92%, but most of them do recover. The lung transplantation, also the lung had been taken from such donors, and there are 20 or so lungs taken in Madrid from such donors, and they do work. Now the controlled DCD, it's a primary group of interest. I will not talk about the definition, but this is here. And we have to realize that for the liver, the recipients of DCD liver have higher risk of, greater risk of graft failure and greater risk of retransplantation in comparison to, and in addition, the high incidence of biliary complications. But nevertheless, this is paper of Scaro from 2009, the patient survival and graft survival from DCD donors, which do differ, but it's not very high. Now, I want to show another paper of Matteo from 2006. The difference is statistically significant from standard donor and from the DCD donor. The same technique has been used, DCD, in a number of countries. In others, it's not legally permitted. In Netherlands, it's grown up in last year. This is the number per million. It's not permitted in Germany, it's not permitted in France, it's not permitted in Poland. The number of DCD donors in comparison to brain dead is shown here, and in US this is last year was 2009, it was
2 minutes, Professor Rowinski.
Sorry? Yeah, I'm
2
finished.
minutes, please.
So I will finish with 2 slides. One is that using DCD organs, we have to use special tests of viability if it's available. graft biopsy, perfusion during the storage with the intravascular resistance and flow, and possibly normothermic perfusion, especially for the liver, which has recently been used. I will finish with 2 slides which are related to my very special interest. We have the Universal Code of Ethics, which is known to everyone, and we are stuck with a number of different types of donors, and organs from these donors do differ. And we need more and more organs. How to choose? And which way to use? An easy way or very difficult way? Easy way is to use living donors, even extended criteria living donors, as in Mayo, for instance, but not only in Mayo. In Poland, there is one center which is also using such living donors. But we still have the ethical rules in organ transplantation which should hold. The dead donor rule, no commodity and no organ trade. Living donor must be healthy. I would appeal to Dr. Delmonico to possibly revise Amsterdam criteria, because everyone is referring to the Amsterdam criteria, but there are no data on the follow-up of not quite healthy living donors. So either, and the organ allocation should be, as it has already happened, should be changed to the utility criteria, not to the medical criteria alone. So I'm not sure whether we are ready to modify or to adjust to the recipient needs code of ethics or not. But this is something which we have to think about. Thank you very much for attention.
I would like to open this paper for discussions, and probably we could discuss the 3 speakers all together, since we're speaking about the same thing. Nobody seems to be happy about the criteria for using a deceased donor. We don't know how to allocate these kidneys to which recipients. Any questions? Professor Domenico, yes? Yeah. You just press the button. Yeah. The speaker.
The down one.
Doesn't speak.
Okay.
Yeah.
2 comments. Yes, there are living donors that are not absolutely well. And yes, Professor Rowinski, I would say to you that the centers are doing that, have an obligation to follow those donors and know about their outcome. And there hasn't been enough data forthcoming yet about that circumstance. So, agreed. But Dr. Awad, I would say to you that we're coming to a better understanding about the distribution of deceased donor kidneys. And it can no longer be by time waiting. Every other organ system has made that decision. Heart, lung, liver, not by time waiting alone. The utility factor, the longevity of the organ has to be considered as well to the recipient that it's being transplanted. So I would say that there is some clarity about that in the deceased donor world.
You think by applying the new system, we will not discard any deceased donor kidneys with the standard criteria? That's a great number of deceased kidneys which are disregarded in the United States. 1,000 kidney a year in 2009 with the standard criteria.
Your point is well taken.
Everybody is after that. Poland, Saudi Arabia, you're more than welcome to send them here.
Yeah. The presentation of those data is a matter of candor, is it not? It is a revelation of the reality. And can a new system impact the reason for the discard of nearly 1,000 kidneys? As it turns out, if one examines, if I may, just for a moment, those 2,700 kidneys, yes, there are systems issues and reasons why perhaps 500 to 700 of those kidneys have been discarded. The others have some explanation. But can a new system impact that? Perhaps so. I think it needs a try. But no one accepts the fact that there were 900 or 988 is what that slide had, SCD kidneys discarded. So we agree. Will there be some change as a result of a new system that would be forthcoming in the US? It remains to be determined, but we cannot accept the current system as it is now. So thank you.
Dr. Mosari?
Wojciech, may I just ask you regarding the expanded or extended criteria donors, age, serum creatinine, and hypertension has been taken into account. Why wasn't diabetes included in the criteria for expanded criteria donors?
It is included in some criteria, it's not in the others, because of the microscopic changes in the kidney, which do occur. And the cause of death, obviously, in addition to what you said. There was one question more.
Dr. Pruitt?
Yeah, I was just going to make a comment on this. For the SCD kidneys which get discarded in our country, a large number of those are Hep C positive. So it's the young guys who die with Hep C and the organs aren't used. It's out of fear of risk of transmissible diseases. It's not that we don't have our issues, but the risk of discarding organs from a non-Hep C positive donor is pretty small.
A comment, please.
Dr. Sayari?
I was just going in relation to what Professor Pruitt said, I'm sure that SCD should be made into two tiers, two levels of SCDs. And I think your 1,000 is in the second tier of SCDs. For example, patients, donors with diabetes alone are not included as ECDs. Patients with HCV alone, patients with long cold ischemic time are not part of the ECD. I mean, these are probably the reasons people discard SCDs because of the worst tier of the SCDs.
How much of our kidneys are discarded, Dr. Shaheen, in Saudi Arabia from deceased donors?
It's not too much. It was one center which was discarding some kidneys. Maybe it was personal opinion at that time. But recently we don't have too many which have been discarded. Probably less than 0.5% from all the kidneys.
The new system will take us into a different realm than SCD or ECD. The new system will take us into a profile index that goes upon the longevity, the predicted survival of the kidney, and then depending upon the estimated survival of the recipient. That's a very important difference in allocation that I would suggest to you needs to be forthcoming everywhere we're considering kidney transplantation.
Thank you very much. We have to bring this to an end.
May I just add one comment
to
the comment of Dr. Delmonico? The registries are obligatory in the countries of European Union. Quite recently, I did the review. Out of 27 countries which has been reviewed, 7 do not have it, and only 4 has any results whatsoever.
Thank you.
Thank you.